One, you may start now.
Good evening, everyone. On behalf of Mankind Pharmaceuticals, I welcome each one of you to the International Speaker live webcast on telemedicine. We are today going to have a discussion on the importance of telemedicine with the international and national experts. To begin with, telemedicine is a term used to describe when a patient receives healthcare services from a provider through technology rather than having to meet the doctor in person. It can take place through video live conferencing, remote patient monitoring, through emails, texts exchanged between the patient and the doctor. Telemedicine isn't new, but the demand for telehealth services has increased in the wake of the COVID-19 pandemic. Telemedicine in today's world has a capability to revolutionize the delivery of healthcare. Given the current focus on the pandemic, efforts to contain costs, improve delivery of care to all segments of the population, and to meet the patient demands. Telemedicine is an attractive tool for success in the above said areas. To talk more about telemedicine, we have our international speaker, Professor Charles Doarn. Professor Charles Doarn is a research professor and the MPH program director at the Division of Public Health, University of Cincinnati College of Medicine. Professor Doarn served as a program executive for aerospace medicine and telemedicine at the NASA headquarters and served as a lead for NASA's telemedicine activities. He has served on the board of directors for the American Telemedicine Association and held several key positions, including secretary, treasurer, and chair of the International Special Interest Group for the American Telemedicine Association. Professor Doarn served at the board of directors for the American Telemedicine Association, and he is the editor-in-chief of the Telemedicine and eHealth Journal since 2005. Professor Doarn is a recognized leader in telemedicine and telehealth as a scholar and teacher, having published over 6 books, over 400 manuscripts, editorials, federal reports, and 46 book chapters on the subject of telemedicine. Professor Doarn was recognized by the American Telemedicine Association with the 2016 Individual Leadership Award for his efforts in the national and international telemedicine program. He and his co-authors recently were recognized with the IAA's 2018 Lunghi Napolitano Book Award in Life Sciences. Professor Charles Doarn's topic for today's presentation is Telemedicine in the 21st Century. Joining with us is our national speaker, Dr. Ramila Murthy. He is a senior scientist at the U.R. Rao Satellite Center, ISRO, Bangalore. He has been on the editorial board of the Telemedicine and eHealth Journal of American Telemedicine Association for 8 years. He has over 40 publications in remote sensing, telemedicine, and societal application of space technology. Dr. Murthy was the chairman of the organizing committee for the Telemedicon 2018 at Amravati. Currently, Dr. Murthy is the Honorary Secretary, Telemedicine Society of India since 2019, and he has initiated to inaugurate 3 state chapters in the past 3 months, and he is responsible in actively promoting the application of telemedicine across India. His topic is Evolution and Growth of Telemedicine in India. I welcome both of you renowned speakers for our session on telemedicine. Professor Charles Doarn, we would welcome you to initiate your presentation. Thank you.
Thank you very much. Good afternoon. Thank you very much for having me. It's early morning here in the United States. I hope I don't have computer problems. I was having some computer problems earlier today. I wanted to kind of give you a kind of a high-speed, low-pass, if you will, of telemedicine, sort of how we got to where we are today, and then, of course, how we're using telemedicine and telehealth in the age of a pandemic, which has affected nearly every country in the world. I was going to try and run this as a slideshow, and hopefully it won't advance by itself. Okay, well, it's not working right. So I was having computer problems, so let me go back. So from a background perspective, it says here, obviously I work at the University of Cincinnati as a professor in the Department of Environmental Public Health Sciences. I do a fair amount of writing, and I also work at NASA headquarters in Washington through an agreement which allows me to be faculty in a university, but then sort of somewhat of a federal employee working with NASA. So when we think of, well, my computer really is messing up now. So when we look at telemedicine today, we want to look at this in historical context. We think of the challenges and barriers, the need for consumerism, the rapid growth in the last 6 months, and the fact that we really can't put the genie back in the bottle, if you will, or we can't put, as we say, the cat back in the bag. We look at things like consumerism. In the right side of the slide, you can see a German vending machine that allows you to buy contact lenses without actually physically going to an eye doctor. You have to have your prescription. And of course, right above you see a Carvana where you can actually buy a car from a vending machine, or perhaps rent one if you wanted to rent a car. And the children's game in the middle is the game called Operation that allows children to play by taking different body parts out without having the buzzer go off. And so I use that as an analogy of the operational concerns that we have. Okay, so the next slide. They're going too fast. My apologies for the technology. It worked fine, yes. Okay. So what I wanted to cover is...
Professor, can you go to the presentation mode at the bottom instead of individual slides? That means solve.
I mean, if I do that, it kind of advances by itself, and that's what I was trying to avoid.
Okay.
So we have here the objectives. We want to understand the current environment. We want to learn the challenges faced in applying these technologies, how healthcare is transforming, and of course, pandemics and the future of human interaction. If you think about human interaction, the way in which we educate one another, the way we attend university, these are all changing to more distance learning with social distancing and wearing of masks and so forth, all brought on because of COVID-19. So telemedicine and telehealth really are very important tools as we move forward. So in this slide, you can see this is the countries that have seen the most coronavirus. There was a previous chart that showed only 2 countries that have not reported any cases: North Korea, which obviously doesn't report anything, and then the other one is Turkmenistan, hasn't shown any cases that we've at least been aware of. That doesn't necessarily mean they don't have any cases, but we're just not seeing them. So because of COVID-19, since January of 2020, we have seen a significant growth in the number of publications that have been coming out, the number of patients that have been seen by telemedicine and telehealth around the world. As an example, if you do a PubMed search or Scopus or Web of Science, you'll get approximately 10 papers published in December of 2019, where there were less than 10 papers up to that point. As of today, there are thousands of papers from many, many disciplines. The application has been exponential. In the United States, they've relaxed, the Trump administration has relaxed guidelines, policies, and laws that allows telemedicine to be practiced and reimbursed around each of our states. And here are two pieces that were written recently that I participated in that sort of bring, on the one hand, brings telemedicine finally to center stage with Dr. Latifi, and then, of course, the one right above is Dr. Bashur and several other colleagues that look at lessons for the future. And we can clearly see that this is creating a paradigm shift. The paradigm shift is one of how do we actually grow this concept. We want to look at, are we really moving forward? Are we really stagnant? And we want to look at some of the challenges that we face. In this particular picture, we see a painting. This is at the University of Pittsburgh. This is a painting from the 19th century on how medical doctors were trained. You can see almost everybody in the audience is male. There's only one female, and she's a nurse. Obviously, in today's world, we have a mixture of male and female in medical schools in all walks of life as well. And in this lower picture is an astronaut looking out the cupola on the space station, looking down at the Earth. So she can see that the landscape in her eyes changes every 90 minutes. As you know, the space station travels around the world every 90 minutes. We also look at some of the things that I've put at the back are some resources and some things that might be of value for you moving forward. In this particular graphic, I want to look at, or I want you to look at, sort of the patient as the center of our focus. So the patient, which we are all patients at some point. We have fears, and we have legislation that affects us. We have payment models that affect us. We have geography, whether it's the traffic in Mumbai or the traffic in New York City or Moscow or Beijing or some small village in the middle of nowhere. You still have access problems because of traffic, because of the mountainous regions. And I know that we've done some work in Mount Everest, and so it's very difficult sometimes to get places that are isolated. But we get there by using technology, and we have developed policies that affect a way of approaching that, and that works out really well. In this part here, what I was trying to do in this graphic is really give you the idea of the things that we develop today affect us tomorrow, but there's this constant loop that we're constantly reviewing our needs and our challenges, and as I say, as telemedicine and telehealth have become more commonplace, there are still issues and challenges that are out there that we need to be aware of that will impact the way in which we might be able to practice medicine effectively. In this image, you see what I try to do here is talk about technology and information. So if you go back into the 20th century, this particular picture here is from a colleague that I worked with in India that actually showed how they monitored and recorded patients with tuberculosis. And so that was done with a book and a pencil or a pen. Today, of course, we have information on thumb drives. We have it in the cloud. And so the question is, how do we go from the computer person on the right, the woman who was working on a computer in the 1950s during, or actually in the late 40s after the World War II, how do we go from that to being able to look at data sets in a different way and have those actually help us change the practice of medicine? So in this next image, we have, hasn't come up yet. I apologize again. The image as it comes up what I was trying to point out in this image is that the standards of care in the 18th century were one where the physician put his head on the patient's chest to hear the heart and lung sounds. That helped Laennec develop the stethoscope, which was developed in 1815, but didn't really take place until the latter part of the 18th century, or 19th century, excuse me. And that then provided a change in the way we practice medicine. The second one is this concept of washing hands. Dr. Semmelweis proved in the 1840s in Vienna that washing hands was a very important aspect of clinical care, because what happened during that period is the midwives did not have a lot of morbidity and mortality when they were delivering babies, but the physicians were seeing a lot of morbidity and mortality, mainly because they were transferring puerperal fever or the bacteria from patient to patient without knowing it, because they were not washing their hands between patients. This next image shows a picture of Laika. Laika was the first mammal sent into space by the Soviet Union in 1957. This dog was monitored from the ground wirelessly. The wireless technology actually had been developed earlier in the 20th century to look both at the water level in the Panama Canal, but also look at rockets that the Nazi Germany was using to send missiles over, the V-2 rockets over to bomb London. This technology then allowed us to then be able to develop the right technology to wirelessly transmit information, and this became very important in the space program, obviously because we have astronauts that are in space and cannot be wired to the ground, and so you have to wirelessly transmit information about physiological signs. And you can see in this picture here where Laika was encapsulated in this rocket. And of course, Heinrich Hertz developed these wireless waves back in the 1880s, and he had no idea what they would be used for. And we can't imagine today not being able to do wireless technology. Although I have to say, I'm using wireless technology right now, and it's kind of slow, so I apologize. This next set of pictures are taken from magazine covers from the early part of the 19th century. One is in a journal called Radio News, and in that article, it shows a boy talking to his physician across the TV. The TV was developed in the 30s, not in 1924, so it was kind of a visionary, I suppose. And then you have, in the second image, you have a doctor actually talking to a patient remotely and then manipulating some devices, and it almost looks like he's using a robotic surgical device. And then, of course, that was in 1929 and 1931. There's a picture of a physician actually monitoring a patient with a device. These devices, many of which were developed in the 1920s and 1930s, really took hold later on in the 1990s, like, for instance, laparoscopic surgery, robotic surgery with Da Vinci robot, and so forth. So then we jump into, from a historical perspective, we also look at how do we do telemedicine in a space program. So in this next picture, you'll see the space shuttle docked at the space station. And obviously, I mentioned earlier how we use this in NASA, and the Russians use it, and I think as China and India and other countries begin to put humans into space, they'll be using the same kind of approach. But in 1993, there was a push to continue to develop our telemedicine system that we used in the space bridge to Armenia, which was in 1988. In this particular example, you can see here this is the picture of me in the middle, talking to another person quite a distance from where I was in Washington. And we're using this web-based tool to actually monitor patients. And again, this is using the World Wide Web, using Netscape actually, in 1994. And people thought we were absolutely crazy. that this was a way to practice medicine, but nevertheless, we did so, and it worked out really well. So from a definition perspective, there are many definitions on telemedicine, and it depends on who you talk to and where you are in the world. And as the editor now of the journal for going into my 16th year, doing that, I have seen more people from around the world try to define it in different ways. And so I will just post a few here. I was asked about 8 or 9 years ago to work on developing a federal definition for the United States, and it was somewhat challenging because each of the organizations that have patients, some of them do so because of legislative intent. In other words, the money comes from Congress, the money goes to support astronauts or veterans or military personnel, warfighters, and then there's the Department of Health and Human Services, which is then responsible for everyone else, right? So you have each one of those has its own definition and own approach to doing medicine. And you can see there's citations at the bottom. The other thing to know, and some of these things you may already be aware of, there's synchronous and asynchronous telemedicine. So synchronous meaning it's in real time, so there's live interaction. And there are many tools that you can do to support that. And then there's asynchronous, which is more of a store and forward. So you develop your case and you transmit it in some way. You could send it by DHL or FedEx or post. You can send it through the mail, or you can send it to a website and upload it and leave it there for someone to take a look at some point later. And that's how we did the space bridge to Moscow and the space bridge to Russia back in 1993, 1994. Again, people thought we were a little crazy. And these slides are not changing for some reason as fast as I had hoped, so I apologize for that. But in the some of the challenges in the 21st century is that people today have mobile phones, they have smartphones, they have computer access, more so than in the past. But we also are keenly aware that people also have limits to what they can and can't do, and it depends on where they are. I asked a colleague just recently why in the United States the African American community has less access to telehealth, telemedicine, and it's not just because of the lack of mobile phone or the lack of bandwidth. There are other underlying reasons, and I'm really interested in exploring how that works or why that works. But in many cases, those challenges exist. The other part that is important to know is leadership and the lack of leadership. If I think about how telemedicine moves forward in the grand scheme of things with, and I'll use our current example of President Trump. Some people think he's a good leader, some people don't think he's a good leader. It's somewhat immaterial in the sense that as we look at how do we address the pandemic and how do we address accessing healthcare when you can't physically go to see the doctor, how can you, and the same thing, by the way, and you saw in New York City how people were dying in a hospital, but they couldn't see their loved ones, they couldn't see their spouse, their children, or their parents. And so using these kinds of tools allow us to broaden that ability, but it can't be for free. I mean, somebody has to pay the bill, somebody has to buy the equipment, and it has to be monitored. There are ways that you want to make sure that there aren't people out there stealing data and so forth. So those challenges, vary depending on where you are. And in that slide, if it ever comes up, you'll see a picture of a rocket and a picture of the U.S. Capitol. And in the cartoon, it has a bunch of people looking at it saying, we have to admit that we're not all rocket scientists, and it takes us a little while to figure these things out. So, okay, well, there's the definition slide. It finally came up. I'm not sure why it's taking so long. Let me try to jump to the educational impact. So part of a lot of what we see today is people are just rapidly trying to apply telemedicine in environments where they have very little or no, I wouldn't say understanding, but they don't have the right necessarily the right tools. And I'm not talking about computers or devices, but I'm talking more about the process and the business side of this. So they have to make sure that we understand what is our need, how do we approach that, what kind of technology do we apply, and then we have to train people on how to do this and do it in the right way. As an example, the University of Arizona, Ron Weinstein and his group at the Arizona Telemedicine program, they actually showed that the best way to see patients on a telemedicine link is using a blue lab coat, not a white lab coat. Most of our physicians wear white lab coats, and that somewhat scares some people. We've all heard of the high blood pressure syndrome where the doctor walks in the room in a white lab coat and your blood pressure goes up. But it's more about the video and the transmission of video signals. It's the same thing in a news report. If you see a news report using the television cameras, you might see a striped shirt vibrating. And so there's things they learn from that. And so these things are based on experiences that many of us have had, and we share that through the educational paradigm, whether it's a series of lectures. We've certainly I wrote a report, did a study here at the University of Cincinnati where we looked at the number of patients, the number of physicians who knew or didn't know what telemedicine was and the terminology, and they all talked about looking at additional training. And so I've actually developed one of the first graduate level certificate programs in the United States beginning this fall for students to take 4 courses to actually gain an understanding and become somewhat certified, if you will. So here's that picture. This is the article I mentioned. And by the way, I did make all these slides available through a PDF. So I believe you, Dr. Shem, who has those, and if you can share them with him, that would be great. In this next approach, I think it's important to spend a few minutes on this particular slide. This is a strategy called IBOT, Initiate, Build, Operate, and Transfer. And this is something we did in the Balkans, both in Kosovo, in Albania, Macedonia, in Montenegro, but it's also been applied in Cabo Verde, which is the archipelago, the island chain off of Africa, and also in Vietnam. And so the main thing here is to walk away with is to have a needs assessment, figure out what exactly you need to do, and get everyone involved and develop a plan. And then somebody has to be the champion. Somebody has to be the one who's really making things move forward. If you don't have a good, strong leader that's supportive, then it's very difficult to change things. And then in this particular model, then as we unfolded this program over a few years, as we developed it, we did the needs assessment, we developed it, we used it, we trained people, and then we transitioned it to the ministries of health. And they actually use it in a significant way in that part of the world. Now, in this particular image here, what I usually have each panel hidden, but what I want to point out here is that somebody comes and says, I want a tree swing. And so you have various different people looking at the customer explained it this way. The project leader understood it, was analyzed in one way. The programmer wrote it this way. The business consultant sold you a very comfortable chair. The project was not documented at all. You can see this blank panel. But ultimately, what you really want is just a tire hanging by a rope from as a swing for children to play on. And so it's really important to look at a project lifecycle to figure out how exactly you want to do it, and then make sure, 100% make sure that it's documented. It's just like a science. If we do a research in the lab and we don't write it down, but we tell everybody, we solved AIDS, we know how to cure AIDS, or we know how to cure COVID-19, but we never wrote it down, we would pretty much be looked at as complete fools. So telemedicine can be practiced in almost every clinical setting, in almost every clinical discipline, including surgery. Now, when I say that, with surgery, it's not, some of these things aren't necessarily 100% ready to go today. We've done a fair amount of work over the last number of years on telesurgery. So the patient is in one room, or one building or one city, and the surgeon is located in a different city. This actually was proven in 2001 with Jacques Marescot when they did surgical procedure between France and New York City, and they were on their way to give a press release on September 11th, and they never got a chance to do their presentation. I mean, they were not harmed in any way, but that was called Operation Lindbergh, and it really showcased that you could operate on someone thousands of miles apart from the surgeon. So we wrote a couple of different articles. The one that's by Bashir, it's the Empirical Foundations of Telemedicine and Chronic Disease, and the one I wrote with Ron Weinstein and Elizabeth Krupinski on in medical clinics of North America, clinical examination components of telemedicine and telehealth. And so we have to walk away from this understanding is that the consumer, we as consumers, are actually demanding things now because we know they're available. If you go to see the physician and you're with your spouse or your children or a friend, and they come out and said, we've done everything we can or could do, and the question comes up is, well, did you get a telemedicine consultation? And I think as we go forward, we'll see more and more artificial intelligence and robotics being put into place. In this image here, you can see the Da Vinci robot is quite large. It's on the left side of the patient, and all the surgeons are standing around waiting for the robot to do something. Actually, they're not really waiting. The robot doesn't do anything without surgical intervention or surgeon's intervention. But it's a very costly device, and the cost savings comes in the recovery. For instance, a physician, a patient who has a valve replacement in a traditional way is out of work or out of in rehabilitation for 9 weeks, 10 weeks, depending on the patient. But a valve replacement robotically, the patient can be back at work within 2-3 days. That's phenomenal. And this kind of technology was developed as a direct result of both NASA, space program, and the military developing technologies for both space travel and for military applications for saving troops in the field. Some of the other things that challenges, there's a growing shortage of physicians. I know in the United States, there are 268 per 100,000 in the United States, but the needs continue to grow, especially for those that are aged. I know places like India and China and in Brazil, where you have much larger populations, there's also a growing shortage of physicians and allied health workers or clinicians in general. And here are two really good publications that kind of highlight that. But the current model that we have, and we're seeing that, is really a failed model. It's not that you can't get really high quality care, it's that the system itself is based on technology and based on approaches that now date back into the 20th century. It's clear that with things like mobile phones, mobility, that patients become more engaged in the management of their health. There are a wide variety of systems and tools that allow us to do that. But as we do this, though, we want to make sure that we understand, what works and what doesn't work. In this next panel, you see it's entitled "Need for Evaluation," and here I have a crocodile trying to get some kind of water buffalo. And here we need to have a strong methodology. We have to do it in stages. We have to look at elusive and observed evidence. We have to look at cost, quality, and access, and we need to publish our results. Why is it important to publish our results? If we don't publish what we've learned, then no one knows that we did it, and that comes down to making sure you can get promoted and gain tenure and all those things at a university. But you also want to make sure that we share our knowledge with those who are coming after us. And I'll look at COVID-19 as an example. I mentioned earlier there were only less than 10 papers in 2019. But since then, I saw somewhere quoted that there's upwards of 20 or 30,000 papers. Now, some of those in the journal I'm the editor of, some of those are more common as as opinions or letters to the editor that say, hey, we tried this in Spain, worked on 500 patients, we want to share that with people. That's not really original research, but it's a significant enough point to be made that can help others that are on the same track of trying to figure out how to best deal with patients, right? In this next panel, we talk about modeling expectations. I think getting everybody involved in writing a business plan and making sure that people understand what it is we're doing, because you can come into your clinical environment or into your village or town and say, we're going to institute whatever it is. And we all know that there's going to be a difference of opinion between people in the same group, but certainly in a city. And it can be edicted by the government. I mean, it's still not clear to me why COVID-19 comes out of Wuhan, China, and affects quite a lot of people, but why it affects so many people in the United States compared to China. Is it because of the way in which the government runs? And in a country like China, you can shut down everything with no matter what the people say. It would be interesting it's interesting to understand how all those people are involved. And then also look at how do you get more revenue? I mean, it's sort of like if I am going to sell contact lenses in a vending machine, I have to make sure that I keep the vending machine in good condition, that I have the products that people want. It's the same with a grocery store or a coffee shop. I mean, these things are very important, but if a lot of people don't necessarily understand, they just want to go out and do something. So some of the key aspects in this next panel, there's an image of King John signing the Magna Carta back in the 13th century about making sure that not only as he is the King of England, but allowed him also to work with the landowners so that everyone had a fair shake or a fair, they were all able to participate in some way. And now we, of course, know that's not true. And the world still is not that way. But there's also the commitment, the financial commitment, and then the added value of that. And this leads me then to just a real quick discussion on cost effectiveness. And in this image, I have both US dollars and rupees to give you an idea that if I look at healthcare as a nation, so in the United States we have 330 some million people, in India you have 1.1 billion, I think it is, something along that line. And so to deliver healthcare to everyone is not an easy task, and it's not an inexpensive task, right? So I know in India, ISRO has done a lot with satellites technology, and I know when I was in Bangalore, we had some great discussions with colleagues about how telemedicine can be rolled out. And I worked a little bit with Dr. Ganapathy at Apollo Telehealth, and you see firsthand how this technology can be put out there. But some people in business, especially business people in a clinical setting, will say, well, if I have to spend $100,000 to develop this capability, I need to see what my return on investment is. How fast can I get my money back? And those are important from a business person's perspective. But we have to also look at the opportunity cost of not doing this, right? If we can't treat our patients effectively in a timely manner, their condition gets worse, and then it becomes more of a problem and burden to society. So those are more downstream costs. So we obviously have to be aware of those. And so, and when you do this break-even analysis, you have fixed cost and you have variable costs. And the next two charts that will be coming up kind of show you a graph about how you have to figure in variable costs and fixed costs. So if you understand the fixed costs of things like rent, utilities, or depreciation, and so forth, then the variable costs, which are personnel, supplies, raw materials. I mean, the price of surgical masks have probably gone way up, as has Lexan, as an example, because every place you go now has to have a plastic shield between you and the consumer. It's somewhat challenging. And so when you look at that formula then that allows you to then graphically represent where you can look at the break even and see how many units I have to sell or how many patients I have to see to make my money back. And the business people are always it's always very exciting to them. That's important to them. I mean, it should be important to all of us, but it's really important to them. And in this next slide, we talk about documentation and business planning. There's elements of the business plan that you need to be aware of and to work on. A lot of times people just come out and say, well, we're gonna do this, and they didn't really think it all the way through. And that becomes a big problem when you're not able to have it documented, right? So in this, here you can see this hieratic script. This is actually a surgical document written some 3,000 years, almost 3,000 years ago, 2,500 years ago. And of course, you read it from right to left. It's written in I'm not sure what language it's in, but it's quite old, but it's a surgical document. But in this business plan, you want to address all these different elements. Okay, I'm going to jump ahead then to the changing landscape. In this next image, you have all these different companies. These companies some of them are only in the United States, and they only do business in the United States, but some do business all over the world. You have Apple and Google. Obviously, you have Apollo telehealth services there in India, and Teladoc, and some of these or even Teladoc and MD Live may only be in North America, the United States, Canada, and Mexico. But you have companies that are now beginning to look at things in a different way. Just consider electronic health record. The electronic health record was based on a standard sheet of the patient and the physician interaction. So as you came into the patient, as a patient came in to see the physician, he or she would mark down why you were there. You were there for well baby care. You were there because you twisted your ankle. You're there because you have COPD, whatever it is. And then that form, what Epic did was basically take that form and computerize the form and build databases behind each entry point. And so that's the way we've been practicing medicine for like 100 years. But we're not going to be practicing medicine that way in the coming years because of things like AI, robotics, sensor arrays, mobile health. I mean, we as consumers are demanding things in a different way. Which then brings me to this whole concept of robotics. Now, we have been able to develop these robots in the lower right-hand corner that actually are now in hospitals around the world. The ones on the top panel are really, this is a Hollywood one from a TV show. This is one from one of the Star Wars movies when the two twins were born. And so you can see these in the lower right-hand corner have been actually deployed. The one that's blue, I don't know if you can see my cursor on that. That one was actually deployed at Landstuhl, Germany, at the height of the Iraq War, if you want to call it a war, where the United States military personnel that were injured were transported from the battlefield, battle space, to Landstuhl, Germany for a second surgery, and then they were then sent back to Conus, the continental United States, for the third surgical intervention to repair, a blast injury or whatever it is. And these robots were sort of tooling around the hospital, and they were sort of getting in the way. And a lot of the doctors didn't like that. So they have a place, and they also have a purpose, but sometimes people don't necessarily see eye to eye or agree on what the nature of those are for. There are also other robotic systems. This device here, very small, it's the size of a marker, a small pen, if you will. It's like a little tiny pen, and that can be actually put into the body to do what it needs to do, and then extracted. So those are obviously things that are coming forward. This image here shows the operating room of the future, and a lot of physicians do not like this picture because they don't want to dress like this. But this image has these larger old-fashioned computers. But the idea is that it's conceivable that you could have an operating room where the patient is the only thing that's not sterile. Everything else is sterile. The robotic systems the array of supplies, much like an automobile manufacturing facility, and the surgeons here doing the work isolated in another room where he doesn't need to physically be in there. And so those things are important. When we look at technology, integrating, information in machines, we look at AI, we look at decision support. Here, this robot actually is on the space station. We look at imaging. Here, Peggy Whitson is doing an ultrasound of her throat on the International Space Station. Here's a cockpit of an upcoming jet aircraft. And so you can see the complexity of these tasks. And so how do we, as human beings, interact with these kinds of machines? Or better yet, how do we begin to look at other kinds of technology? Here you see, this is a cartoon of a 3D printer printing organs, but you can now print medical devices, and they do have a 3D printer on space station. And so it's very important to look at how things are changing moving forward. The pearls of wisdom, I think it's important. This is Winston Churchill made this statement, to improve is to change, to be perfect is to change often. And I have to say, there are a lot of people who will refuse to change. They either like the status quo, they don't want to be different, they don't want to learn a new way of doing things. I had the pleasure of writing a manuscript with Dr. Michael Debakey, who passed away at the age of 99 about 8 or 9 years ago. And he was really adamant about technology and how it could impact healthcare. He actually worked on the left ventricular assist device, which is something that cardiovascular surgeons use. And it was based, the impeller blade inside the pump actually was the same technology they used on the space shuttle main engines, fuel pumps. So clearly, adding technology was important. So from a resources perspective, there are all kinds of articles written, all kinds of journals. This is the Telemedicine journal that I'm the editor of, the one with the red banner on top. Journal of Telemedicine and Telecare comes out of the Royal Academy in England. And you can see that there's all kinds of journals that now are being used to promote the research that's being done. And in fact, it finds its way into the more medically oriented journals, JAMA, the New England Journal, the British Medical Journal, and so forth. There's also a fair amount of textbooks. This family medicine textbook just came out literally 2 or 3 days ago, and my chapter is chapter 68 on telemedicine. So it's the first family medicine textbook that actually has a chapter on telemedicine. I've written some stuff in this book as well. But the American Telemedicine Association has these guidelines there's a whole bunch of them. There's many more than just the two of these. And they also have done a gap analysis in the states, in our 50 states. And these are pictures from 2016. But if you go to this website, you can find what happened last year. And they actually do an analysis of each state. And they apply to the United States, but the background and the information could be valuable to any place in the world. Actually, it's not just specific to us. There are also a fair number of other things that we've been involved in. I remember back in 1994, I was at the International Space University summer course, which was in Barcelona, Spain, and the students had 2 projects they could work on: robotics or telemedicine. So I was on the telemedicine faculty, and the students developed this book it's called Gates, the Global Access Telehealth and Education System, on how do you use telemedicine in the age of a pandemic. You think anybody's paying attention to that book today? No, because people don't want to change. This book here is a book we wrote on a multinational telemedicine system for NATO. Also talks about disasters in, guess what, pandemics. And again, no one's taking a look at this one. This one here that's yellow, this is a G7 report about how telemedicine systems interact with one another and how you need to have standards and so forth. This came out of a G7 meeting, and I was one of the authors along with Jay Sanders. This report, when it was published and given to the U.S., the person in charge on the U.S. side, which happened to be Don Lindbergh, the Library of Medicine director, he threw it in the garbage, didn't think it was of any value. And this book here is this concept of engineering life sciences, you have the engineering, you have the life sciences, and you have the medical doctor, all in working collaboratively, but where the astronaut, where the patient, where your whatever it is in the center in these Venn diagrams, that kind of highlights how do we look at this from a human systems perspective. I think that's very important when you're designing a telemedicine system, when you're applying it, very important. And in this last slide, the United States has a thing called the Telehealth Resource Center, so you can see how every state is split into different sections where they can, there's a centralized, like I live here in Ohio, there's a central location where these are funded by the government, but they also provide the people who live in those regions, those states that are different colors, the actual information they might need for their area. And in this last slide, this happens to be a slide taken from the movie The Martian with Matt Damon. And I just say that's what the duct tape is for. So I apologize for some of the slides not advancing as fast, and I will then stop there. Thank you.
Thank you, sir. Thank you, Professor Charles, for the interesting session. I would now like to introduce and call on board Dr. Murthy Ramila, and his topic would be Evolution and Growth of Telemedicine in India. Welcome, Dr. Murthy.
Good evening, colleagues and friends in India, and good morning, Professor Charles and colleagues from other parts of the world. Yeah. Is this okay now? Professor
Yeah, I can see it. Looks good.
Yeah. Good evening once again, and it is nice to share this platform with the Professor Charles, though we were co-editors or on the board of editors for the American Journal of Telemedicine and Events for almost 8 years. This is the first virtual platform we are sharing together, and thanks to the organizers for this meeting. So before we get on to the subject, I just like to mention two phrases from the Indian system. What we believe is Loka Samasta Sukhino Bhavantu, means let all the world be happy, let all the people be happy. And Arogyam Mahabhagyam, that is, health is the biggest wealth. These two things, though they were there for many centuries in the system, now only in the aftermath of the COVID, they are getting more significance and value, because thanks to the COVID, we are wishing for the health and well-being of not only we and us and our family, but also all our neighbors and everywhere else. And also all the people who have amassed wealth, nuclear bombs, space systems, or the supercomputers, and all the people, they could not make any use of that, and everybody from the billionaire to the man on road is gripped by the same fear of COVID-19. So these two things I would like to establish. So, in the light of that, what the Indian system believes, and that truly for anybody else also, is not just the lack of disease is not the health, but the well-being in physical, mental, and social aspects is the true health. And healthcare involves so not a disease management, but prevention, maintenance, and management. And luckily, telemedicine is useful in all the three phases of this prevention, maintenance, and management. So now when we go back to the historic chapter, the origin of telemedicine in India, to our knowledge, is ISRO's satellite-based communications for the use of telemedicine, for the advancement of telemedicine, or for the application of telemedicine, where the WeChat terminal was there at the doctor end and at the patient end, and with the necessary medical equipment at the patient end, and the doctor or the expert listening to the patient and the doctor, which we call as a remote doctor, and giving his expert opinion. This initially started This initially started as a point-to-point system where one doctor, one village remote doctor was able to speak to one specialist doctor. And thanks to the technology and the adoption of the technology, multi-point to multi-point system has evolved, wherein multiple doctors, multiple remote doctors and multiple specialist doctors were able to connect and talk to each other. When we talk of this, ISRO's telemedicine system started in 2001, connecting one district hospital to a specialist hospital or a tertiary hospital in the state headquarters by a satellite communication was itself a great revolution. And thanks to all the advances in the technology later, many more things have come and the things have gone in a much faster mode. So naturally, more partners and more technologies and more applications have seen the light of the day. So SRMC Chennai, Apollo Hospitals, SGPGI and PGI, Narayan Hrudayalaya, Shankar Nethralaya, Arvind Eye Hospital. I can't list all the people, but these are all the pioneers in the application, adoption and the promotion of the telemedicine in India. And thanks to that, the additional technologies like the internet, broadband, wireless technology, state WAN networks, and fiber net or grid in some of the states, they have added so that everywhere satellite communication is not required. And frankly, today satellite communication is limited to the areas where the other mode of communication or connectivity is not available. And also, though it started primarily in the cardiology, it has extended to many specialties like diabetes, ophthalmology, dermatology, psychiatry, and many more in the time. Subsequently, this fixed telemedicine network in a village hospital connected to a tertiary hospital was not serving all the purpose. There are still many villages where this facility is not available. So, in this, some of the hospitals and medical research institutions, they have come up with mobile vans, and notable among them are the very beginning of this was done by Shankar Nethralaya and Arvind Eye Hospital, who have developed an extraordinarily convenient and useful and all-in-one mobile van, almost a bus, was converted into a testing laboratory, testing place, and then grinding the lenses, and then dispensing the lenses also, and then referring the patients to the specialist hospitals as and when required. And this luckily was adopted by others later in the field of diabetics also. Because unfortunately, even in the year 2020, many of the people don't have the preventive check or an annual healthcare checkup. So diabetics is sets in, and then only later, once the vision is lost, they think it is 40 plus, so we are getting the vision loss. And only when they go to the doctor, they know that there is a onset of diabetics already, and they don't really know when it has started. So thanks to these two mobile vans and their philanthropic work, these buses go to all the villages and then they will be screening, and more importantly, their promoters or the advocates will be going 3 or 4 days in advance and announcing where the van will be coming and standing, and then they will be dispensing all the medicines as well as the glasses which I mentioned earlier. So whatever is the technology and whatever is the application and whoever is the user, ultimately it has been accepted. And today we know this by different names, by telemedicine, e-health, m-health, telemonitoring, or whatever it is. And also the global medicine, telemedicine market is growing. So let's not bother about the numbers here, but the trend of increasing the telemedicine market that involves the hardware, the software, the services, and the connectivity, etc. Now I come to the Telemedicine Society of India, which I represent as the Honorary Secretary, which is a scientific society of doctors, technologists, scientists, engineers, academics, and industry people, and the hospital administrators, and also, last but not the least, is the NGOs who have done excellent service in the remote areas in the inner parts of India. So, Telemedicine Society of India has crusaded for telemedicine guidelines and recognition for more than a decade. and it has formed several working groups for fostering telemedicine growth in India after these guidelines were issued in March 2020. And it has trained more than 6,000 doctors in a period of 2 months, and it is working towards training more doctors and students. So as I mentioned, though we have been struggling and trying to promote and propagate the telemedicine for almost a decade and get a valuable recognition and legal authenticity for that, thanks to the entry of Dr. Vinod Paul in the year 2018 in the Telemedicon 2018 at Amaravati conference. We got a really listening ear from the government of India side, and this we have followed up with the meetings at Delhi and at ISRO Center in Ahmedabad, and he has promised to definitely carry forward the message, the usage, and the benefits of the telemedicine to the government and the Ministry of Health, and our other colleagues at Telemedicine Society of India also have continued the effort. And then, as a result, we have seen the telemedicine practice guidelines issued by the Ministry of Health and Family Welfare on March 25th, 2020. This is really a recognition for the Indian telemedicine program by the government of India. Though earlier it was not illegal, there was no document mentioning this or identifying this as a legal practice. So it is recognized as a new tool for national healthcare delivery system, which will be really ushering new centuries or new eras in the healthcare systems in India. So the background for this is the ministry and the government of India has decided to maintain the telemedicine in the healthcare system to minimize the inequity and barriers to access. We know we don't have to explain the digital barriers and the geographic disturbances and the long distances between the rural and remote areas in India. And so the Indian digital health policy advocates the use of digital tools for providing the health care to everybody, irrespective of their location, and it lays significant focus on the use of telemedicine services for all the possible and potential service areas. So these guidelines will serve as an aid and a tool to enable the registered medical practitioners who are neither who are probably either not aware of the telemedicine or who are aware of the telemedicine but are apprehensive about the legalities and the practice. So now these guidelines have really ushered a sense of confidence and then authenticity to the telemedicine practice in India so that it is able to enhance the healthcare services and access to all across India, irrespective of the location. So these guidelines, I will not get into the micro details, but basically touching the guidelines, they will provide the practical advice to doctors, and healthcare workers are also encouraged to consider the use of telemedicine as a part of normal practice. Earlier, there used to be one telemedicine room in some of the hospitals and one specialized operator, and doctors used to go there and then talk to them on a rotation basis. So it was seen as a kind of a special service or an additional service. But now the telemedicine has become a norm of the practice of telemedicine, and it is getting into the day-to-day practice of the healthcare delivery. So these guidelines will provide the doctor to give the care based on the current information, available resources, and the patient needs, so that the patient and provider safety are ensured at the same time. The beauty of these guidelines is the patient safety and security of his information, as well as the safety of the provider and the digital data is very well encapsulated in this version 1. Already some corrections have already amendments have come, and more things will continue as we progress. So as I said, I will not get into the details, but the contents of the practice guidelines are right from the definition of telemedicine, telehealth, who is an RMP, and very thankfully it has excluded the specifications of the hardware, software, connectivity. What it says is you use any available and then best possible technology and solution, but get connected and provide the healthcare to the needy people in the needy hour. So it is providing a clause for certification course to all the intending RMPs in a period of 3 years, and then preparations are on to define the curriculum and the mode of the examination and the conduct of the examination as well. So basically, these telemedicine guidelines provide opportunities for four kinds of connectivity between multiple players. One is patient to the RMP, the other one is a caregiver to the RMP. In case of aged people, elderly patients, or the children, and in the one RMP to another RMP for expert opinion, or in the village areas or in the truly remote areas, health worker to an RMP also. They will provide the guidelines and then access and allow an uninterrupted flow of information between any of these two people or multiple combination of these people. So those were the guidelines for the practice of English system. But later the PCIM has come up with telemedicine practice guidelines for the Indian system of medicine, that is Ayurveda, Unani, Siddha, and later in the homeopathy also the Council of Central Council for Homeopathy, they have come up with the guidelines for homeopathic practitioners. And more importantly, the telepsychiatry operational guidelines 2020 were also defined and released. They will be used in conjunction with the existing clinical standards, protocols, policies, and the telemedicine practice guidelines 2020. The beauty is, irrespective of the location of the patient and location of the doctor and the mode of specialization or the system of medicine he is practicing or he is planning to adopt, all that systems have now the telemedicine practice guidelines defined. So now, thanks to the positive outcome of COVID-19, 2 decades of the effort from Telemedicine Society of India and many other people and institutions is almost equal to, or I can say less than the 2 months of the post-COVID scenario, post-COVID period. This COVID-19 on one side and the issue of the telemedicine practice guidelines on the other. They have brought in a new paradigm, that is the technology or the industry push. We have been meeting every year for the annual conference and then writing papers and promoting telemedicine and almost requesting people to use. Now, the reverse has happened. Now, the consumer and patient pull has started, and we have seen the maximum inquiry, maximum knowledge, and then maximum dissemination of the information and the interest towards the telemedicine in the last 2 months and rather 3 months period from the March. So, thanks to this, the IRDA, the Insurance Regulatory and Development Authority of India, also has instructed all the existing health policies to cover the telemedicine, which is really a boon for the patient as well as for the doctor, because the aim and goal of the insurance agencies is to maintain the wellness of their patients or their clients so that their burden or the financial burden is reduced. So thanks to that, they have instructed and the insurance company started to recognize the teleconsultation, and today it is ushering a new era in the practice of telemedicine. So how the telemedicine was useful in the COVID time? This video visits in place of personal visits, which have brought really a big relief for the non-patients or non-COVID patients who need who have to regularly go to their chronic diseases to the hospital. And now that has reduced the risk for the non-COVID patients to visit the doctor unless it is essential. And only the smaller subset of the high-risk patients only have to go to the clinic in a personal mode after the tests are conducted, and reducing the burden on the hospitals also, because in the normal times probably they may be wishing for more number of people footprints, but now in the times of the COVID they want less number of people because the isolation what they have to create and the sanitization efforts required and also the healthcare requirements to meet the inflow of more number of patients is becoming a burden on the hospital. So that is also reduced. and so it is also equally reducing the risk to healthcare workers. Though PPE kits and all others are there, still they are exposed to more number of people, may be positive, corona positive or may not be positive yet, but still the risk factor is increasing day by day, and so it is reducing this telemedicine practice, is reducing their burden. But still there are two challenges. One is out of hospital management is the real testing in the corona. So the testing purpose, and for the testing purpose, patients have to move into a clinic or to a testing laboratory. That is still one of the challenge. And another challenge is, though we have been promoting and propagating the telemedicine for 20 years, not everyone and everywhere is equipped to take the benefit of the technology or the availability of the telemedicine. They have come in, many apps and many websites and many services have come in the last 3 months in the midst of the COVID, but still we have to equip ourselves to a larger scale in the times to come. So all said and done. So this is the past. Now what is the future? As we have observed, we know that telemedicine is nothing but it is a combination of the medicine along with the communication, electronics, information technology for the application in the medical area. So all put together is the telemedicine, and the development happening in all these areas are really helping the advancement of the telemedicine as a practice. And the more important thing is the convergence, the combination of these services and the convergence of their integrated availability is really paving the way for the telemedicine, and which is really serving the people as well as the government in reducing the burden of creating a brick and mortar hospital. Because this telemedicine, if really applied well, can replace, not exactly replace, at least it can supplement the brick and mortar hospital with an information structure. So it is a transformation from an infrastructure based healthcare system to an information based healthcare system, which we call as moving bytes of information instead of moving bodies or people from place to place. We will briefly see the developments in the areas of information, electronics, and communication. In communication, today we are overwhelmed with so many technologies and their combination. We have a variety of connectivity options. Bandwidth is increasing day by day, and the speed is increasing, latency is coming down, and space-based services are now today augmented with many land-based and wireless services. 3G and 4G have gone, and now we are just entering into the era of 5G. And IoT is another advanced area which is promising for the seamless information transfer. And also the combination, not only the individual technologies or the advancements, but their combination and the collaborative solutions are really helping the telemedicine growth. And next big thing, as I said, is the 5G, which is going to come very soon in India in the operational level also, which is promised to have an ultra reliable, low latency communication system. So it will really revolutionize the connectivity option. Today itself with the 2G, 3G and 4G, people are able to really see, because we are still not into the era of robotic surgery to a operational level in India. So for all other practical purposes of telemedicine consultation, the 3G and 4G are really serving the purpose, and this 5G will really revolutionize the connectivity and the uniform availability of the healthcare to all the people. Similarly, the information in the IoT is another Internet of Objects or Internet of Things is another tool which is going to really develop and provide a great combination of resource for the people in the healthcare delivery. And thanks to the advancements in the technology, again I mentioned their convergence more than the individual technology development. Their convergence is really providing an opportunity and a resource for a seamless flow of information from one end to the other and almost in a real time. So in the electronics also, we don't have to mention, we have seen the evolution of the mobile phone and the reduction in their size and the increase in their camera capacity, computing capacity, display capacity, and almost today mobile has replaced a computer and even a laptop also. So the nanotechnology, miniaturization, wearable devices, implantables for monitoring the chronic patients, and the smartphones, everything is really helping. So all these things in their individual capacity, they are growing, and in the convergence effect, they are really helping. Previously, Professor Charles has shown the 3D printing graphics, but now the 3D printing has become an operational level, and then really it is going to revolutionize the healthcare delivery in the times to come. Similarly, the handheld devices, their IoT-based connectivity, and their seamless information flow, and a really reduced economical level of operation, owning, and the miniaturization helping the hand held devices or everything carrying a hospital almost in a backpack. They are helping the telemedicine growth in India and across the globe as well. So in the information technology, we don't have to mention India is a leader and providing information technology solutions to the globe. And this is really propelled by the availability of higher computing power, lower cost, big data storage, cloud computing, artificial intelligence, and machine learning. And definitely the database management, which is going to have a real requirement and an impact in the times to come when the number of consultations increase and when the number of patients across India or across the globe they get connected, their data has to be stored in a secured environment and the data mining tools have to be applied, and then they have to get the right information at the right time to the right place. So these are all really providing the tools for the advancement of the telemedicine in India. Thanks to the previous mention by Professor Charles. Yes, we in India we have a host of satellites. I'm lucky to be part of this organization, Indian Space Research Organization, where we have a different host of satellites providing the weather information, providing the remote sensing information, communication connectivity, and the navigation. So all these hosts of satellites, they can be utilized definitely in the cycle of the life cycle of the healthcare management. As I mentioned in the beginning, disease management is not the goal, but the healthcare management right from prevention is the goal. So the prevention, preparation, monitoring, management, and then the corrective action. These loops can be well managed with the benefit of the converging technologies of the satellite, ground systems, computing power, and artificial intelligence, information technology, all definitely at the center of the cycle is the patient and his healthcare, thanks to the effective utilization by the medical fraternity and the healthcare providers. So this is one example which earlier we were showing, but now this has become a common in the times of COVID. Satellite data applications for healthcare management, where the outbreaks in the different locations were being monitored and then alerts were being issued. And today we are using this information right from the CDC in the USA to the Ministry of Health in the India. Everybody is using this graphical and pictorial information to give the alerts to the people in the particular territory where they are in the whether they are in a red zone or alert zone or a green zone, etc. But all said and done, is everything really rosy? If so, what is the problem? As I mentioned, there are benefits. There are so many technologies. We have patients on one end, we have medical doctors on other, we have information technology, we have a communication technology, everything is there. But then, like water everywhere, but nothing to drink. Similarly, earlier, this convergence and the large scale adoption of the telemedicine was not available. And now, thanks to the COVID and the issue of the telemedicine practice guidelines, India is seeing an uprise in the application of the telemedicine. But still, there are some issues which are difficult, but definitely not insurmountable. They are changing patient or physician needs, and then coming out with more user-friendly technology and interfaces. Because some of the grandparents they will be converging and communicating with their grandchildren in the abroad happily with the Skype or Facebook or WhatsApp. But again, to the old generation doctors, when we go in some hospital, they say, no, sir, we are not aware of the information technology or we are not computer savvy. But still, that can be overcome if there is a will. And with minimum expertise to operate, once the systems are provided, it is very much possible to penetrate and break that barrier. And the reinvestment cost, earlier also Professor has shown the fixed cost and the variable cost. So definitely we have to think of the reinvestment cost, and but still, thanks to the mobile telemedicine today, we don't have to worry much about the large scale investment cost in places where it is not a satellite based communication. Because definitely still, in the case of satellite-based communication, where no mode of other communication is available, there has to be one antenna, VSAT antenna, receiving equipment, RF systems, and a UPS, and a computer, and a TV, etc. But still, that is required in places like the Indian frontiers and the Siachen Glacier and in the army posts where they are not having any other option. So definitely their cost is not a factor, but the availability is an important factor which is really serving the purpose. But in case of other hospitals and other urban areas, mobile telemedicine is really filling many of the gaps which I have mentioned. One of the important things or apprehensions from the doctors as well as patients in the healthcare is the privacy and security of the information. Thanks to the detailed guidelines, these guidelines, the telemedicine practice guidelines of India, they have dealt very well with the privacy and security of information and the user acceptance and the user information and the messaging to the user in terms of the prescription as well as the consultation and the history and the record. So all these things, there are problems on one side, but definitely if there is a will, there are many ways like data encryption, secure connections, and multi-tier authentication, which will, to the most possible extent, nullify the negative sides or the apprehension in the security aspect. And as I said, telemedicine through mobile, because today mobile is a walking computer. So they are filling many of these gaps and they can make it ubiquitously available, and they really serve the people irrespective of the location of the doctor as well as the location of the patient. So telemedicine we know is now looking like a blessing in disguise. But will it win the public trust? That is the test of time. Because right now, what we are seeing is only the interest and the inclination to use the telemedicine. But really, we have to see whether it will win the public trust, because the people we have seen, and the professor also has mentioned in his presentation earlier, you may provide all the technology, all the high level equipment, and the super fast connectivity. But still, if there are no champions to utilize that application, to utilize the technology, and to serve the people. Definitely, these technologies alone, they are not a panacea. But the people, their participation and their willingness will really provide the right technology to the right people at the right time, so that the right information goes to the right doctor, and then the real benefit comes out. Otherwise, without the champions, we have seen in earlier cases when there is one telemedicine room operator or the system operator is not available, that room is shut. For that day, telemedicine operations are not there. This is a very pathetic condition. And some systems where the annual maintenance is not carried out, or they are not carried out in a systematic manner. But those days have gone. Now they are seeing the benefit of the telemedicine. More than the benefit, the need and urgency of the availability of telemedicine, and it is a patient demanded pull. So definitely we believe, hope, and wish that these situations will change and it will be equally available in the right manner. So finally, who is driving the telemedicine? Earlier we have seen the technology was seen as driving the telemedicine, because there was a technology push right from our organization ISRO also. Though it is not our main line of activity, we have started this telemedicine as a demonstration exercise. That is a proof of technology demonstration that telemedicine can be achieved through the use of communication satellites and the remote sensing satellites, connectivity and information technology, which will provide the doctor an informed, which will enable the doctor to take an informed decision. So we have come to the inflection point now, whether to see whether it is a technology revolution or it is going to be a behavioral revolution. If you see the last 2 decades, technology revolution has already been witnessed. Now what is impending and what is demanded today is the behavioral revolution from the patient, from the technology providers, from the doctors, as well as the hospital administrators, and definitely not to forget the medicine and the patient at the core of all these activities. So, what is the ultimate dream? Finally, we should have a telemedicine grid for India, that is a connectivity between any nook and corner of India, right from the Lakshadweep Islands to Andaman Nicobar to the mainland of India. And towards this, the government of India is planning 160,000 health and wellness centers across India, and 60,000 are going to be rolled out in phase one. And telemedicine facility is going to be available, made available if it is not available, or it is going to be upgraded at all the health and wellness centers. And many public networks like ISRO are working, and the common service centers and the national knowledge network NKN, many more are there. So now what we need is the convergence and confluence of all these technologies, service providers, and also the convergence of the public systems like ISRO and others, along with the private hospital network. Many hospitals in the private domain, they have their networks who are providing the telemedicine services to the far-flung areas right from Jammu Kashmir to Northeast and to Andaman Nicobar and Lakshadweep Islands. So definitely the convergence and confluence of the public-private systems will be adding and really making a virtual telemedicine grid for India. And in addition, with this mobile connectivity and the telemedicine guidelines allowing the patient to directly get connected to the doctor, the household connectivity in some states through the fiber grid and the mobile individual based connection, all are going to come. So this is definitely, so far it was seen like a philanthropic activity or an extended activity, but that is not the case anymore. Now it is going to provide more opportunities, business opportunities for the startups and the other entrepreneurs and connectivity people, hardware and software. And we should not shy while for talking about business in the healthcare, because ultimately in the traditional system also healthcare systems 99% are costed systems. So here also it is going to come at a reduced cost. So ultimately we should be able to achieve this one country and one healthcare network, so that everybody can feel safe that they have a doctor in their home or they have a doctor in their pocket in the form of a mobile app or a mobile telephone. So that's the thing. And I would like to acknowledge all the doyens of the telemedicine in India and the individuals and institutions involved in the mission telemedicine who have been working relentlessly and tirelessly, though the takers were less, for almost 2 decades. And the Telemedicine Society of India, which is spearheading the growth, application, adoption, and the availability of the telemedicine across India. And not least, the organizers, that is Act for ESH and the Mankind, for their support. So I would also like to thank and express my happiness to share the platform with Prof.Charles. As I mentioned, we were on the board of editors for the eHealth Journal of ATA. Thank you. And this is my last slide with my birthplace, Rajahmundry in Andhra Pradesh, in the middle, and the Gaganyaan mission, where I am working now, that is the human space program of the Indian space program, which is really going to see the new dimension of the telemedicine in India, talking from Earth to astronauts in the space. Thank you once again for all your kind attention. Thank you.
Thank you, Dr. Murthy. Thank you, Dr. Murthy. Yes.
Yes, sir.
Right. Right. So I would like to begin with thanking both the eminent speakers for their very interesting and
I hope I was within the time.
so I would like to first mention that we have had close to yes.
Go ahead, sir.
Right. So I would like to now mention that I have had many questions that have come from the viewers, and I definitely firstly would begin by apologizing that I would not be able to cover all the questions that we have received, but I will take the most frequently asked questions and put it forward to you, Dr. Murthy and Professor Charles, so that we can get your answers on the same. Firstly, I would like to begin by asking the most common question that we have received from the audience regarding the medico-legal aspects of telemedicine in the West, and what are the medico-legal aspects of telemedicine in India. Can you please both of you share some on this particular topic?
So from the United States perspective, there are, as you know, there are 50 different states. So each state in the United States has a mechanism for licensing physicians. And if you're licensed in California, for instance, you cannot practice medicine in Virginia unless you have a license. And so you have to take an examination, pay a fee, and then you get your license. There has been an effort for, I think, 35 states that have come together in what's called a compact, and which allows physicians to cross state lines to practice medicine. That's the second part. And then there's the whole legal implications that come out of HHS, the Department of Health and Human Services, which is in the Trump administration has relaxed some of the guidelines for reimbursement and for legal implications. Now we all know that as new technologies come on the scene, as it were, you're going to see more. And of course, in the United States, I think there's a lawyer in everybody's closet. I hope there's no lawyers on the crew. But in the sense that they actually, we want to make sure that the quality of healthcare is the same or better. We want to make sure that the quality of service is to the best it can be, and there's reliable technology and reliable communication. Because if you can't provide the best care, then you're going to find a lawyer is going to file a lawsuit, or someone's going to file a lawsuit. And we've seen a few that are related to more pharmaceutical industries, where a doctor's prescribing medication that there shouldn't be across the state line that they don't have a license to. So those illegal barriers continue to erode and move away. But we also know that as new technologies come online, whether they're robotics or AI, that there is going to be legal implications, and we just have to keep abreast of those. The other part is then the whole legal implications of new technologies in the sense of being able to keep up with technology. So the process of getting new inventions out. So say, for instance, there's a new vaccine for COVID-19 that comes out by Moderna sometime this fall. It may be very effective, but you know that the process of getting things approved through the Food and Drug Administration takes a long time. And so there's ways of expediting that, but often takes an act of Congress or a presidential executive order. So I think there are legal issues. They're being ameliorated on a daily basis. And of course, the issue is we have 50 different states with 50 different approaches.
Correct. Dr. Murthy, any suggestions from your end on the medical legal aspects in India?
Yeah, in India, first of all, I would like to say before all the stories, there are no legal constraints in the practice of telemedicine in India. The telemedicine practice guidelines all require fees and RMP to be registered with the state medical register or the IMA as per the IMA Act 1956, and there are no barriers of practice of telemedicine across India, and so any doctor from any state can provide a teleconsultation to anybody, any patient in any state of India. For the time being, these telemedicine guidelines, they are limited to the practice of telemedicine within India, but not from outside to India or neither from India to outside. Probably in the future, the times it may change, but for the time being, that is the thing. And what they say is, all the registered medical practitioners practicing the telemedicine should undergo a certification course in the practice of telemedicine within 3 years from the date of publication of the practice guidelines. That is within 3 years from March 25th, 2020, so that they are aware of the advantages, benefits, as well as limitations and the do's and don'ts in the practice of telemedicine. But otherwise, they shall uphold all the same professional and ethical norms and standards as if they are practicing a conventional telemedicine, and all the rules applicable in the in-person care are applicable to the telemedicine as well, only with the additional boundary or the additional point of intrinsic limitations of the telemedicine have to be kept in mind while practicing telemedicine. Will that suffice? Dr. Shambhu? Are you able to see me?
You have to unmute your mic.
Dr. Shambhu,
Yes, am I audible to the team?
Yeah, now only you are audible.
Yes,
Yeah.
am I? Yes, yes.
My
Okay,
answer
so
was
the
it
next question.
sufficient?
Yes, it was. Yes, it was.
Yeah.
So my next question is, we have seen that telemedicine has taken a front stage right now in India due to COVID-19. So wanted to know as to what are the general, usage of telemedicine in the West, and will telemedicine have the same kind of acceptance post the pandemic? Wanted to know your points here.
Yeah, let's first by Professor.
So in the United States, telemedicine has gone from 0 to 60 in a matter of a week, very, very fast. There was a clinic out in Seattle that did an average of 1 or 2 cases a week, and at the height back in April, they did, I think, 3,000 or 4,000 a week. So there clearly has been adopted. Telemedicine is used in telestroke. It's very important in a rural community hospital. If someone comes in looking like they have had a stroke or are having a stroke, you want to get TPA on board as quickly as possible. If you do not know what you're doing, I mean, some emergency room physicians are really good at identifying a stroke, but some rural physicians are not. And so if you put TPA into the body, it may very well cause the person to die or get worse. But if you don't put it in, then you have a problem with the patient expiring or dying. So there's this concept of using the linkages between larger hospitals or trauma centers to smaller community hospitals where you can do telestroke. There's also telepathology, where slides of pathology slides are sent around. Also remote monitoring, dermatology. We've done some work with inflammatory bowel disease and patient medication. We've used it for telenursing and monitoring nurses, patients in retirement communities that are remotely located. I mean, within the facilities. So it actually can be used and is used in the United States for almost every clinical environment, aside perhaps from doing telesurgery. But there are ways of linking the surgical field or the surgical room to a classroom for teaching.
Yeah.
Right. Thank you. Dr. Murthy, please. Yes.
As I mentioned, initially probably it started with the telecardiology. Later, many applications and specializations have started. But still, as I mentioned, and now seconded by Prof.Charles, the last 2 decades of effort by Telemedicine Society and many other industry partners is equal to or even less than the last 2 months of the post-COVID scenario. So now it has got a recognition and as a viable or an alternative solution. Definitely in the times to come also, the people will be using this, we believe, and they should use also for 2 reasons. One is the doctors say in 90% of the cases, the doctor doesn't have to really touch a patient to give a diagnosis or to give a treatment. So in that case, they don't have to really physically travel personally to the doctor. So definitely they don't have to go there. So, and like we are seeing now today, you see the work from home culture and the online classes for the kids, LKG to university, they have started. That is a force of the nature or a force of the COVID. So, same thing will be applicable and it will have a lingering effect, thankfully, a positive effect for the application and expansion of telemedicine in India as elsewhere.
Right. Right, sir. Right, sir. Thank you. So just before I move on to the next question, I would like to tell the live audience that after the Q&A session, we will be giving a live demo as to how a telemedicine app works, specifically on the DrOnA app. So those who are interested would request you to kindly wait till the Q&A session gets over so that we can give a live demo of the DrOnA app. So moving, sir, to the next question that I have for you. What about the security aspect of a telemedicine app? When we talk about end-to-end encryption of information, how easy or how difficult is it for someone to misuse the regularly prescribed medicines without the consent of the doctor through the app, through the telemedicine app? If at all, yes.
Is it to me?
I think either one. With regard to medication, I mean, if you get medication at the pharmacy and you take it home, I mean, you pick it up physically, you take it home, there's no one that's going to monitor whether you take it or someone else takes it or steals it. If you get your prescription via telemedicine from your physician and someone else takes the medication or steals it, no one, there's no way of knowing unless you begin to develop technologies that allow you, and I'll use this bottle of water as an example. If you put technology in the lid and the lid knows that you as the patient opened it up and you as a patient took that pill out, there's not going to be any monitoring of the pill itself, but there's ways of doing that. But that almost becomes too controlling, right? That's kind of like a science fiction movie where everything in society is controlled, and we obviously can't do that. The concern would be more along the lines if you are asking for a prescription, say for some opioid, you need some Percocet or OxyContin, and you talk like I actually had kidney stones back in February where they had to actually put a catheter in the bladder up to the kidney. I don't recommend that for anybody, but very, very painful. And I had run out of my Percocet. They gave me, I think, 8 tablets. I was allowed to take 2 a day for the pain and then just go to Tylenol. So we were getting ready to drive across country from about almost 1,000-mile drive out to the central part of the country. And I called him and I said, can you prescribe, 5 tablets so I can pick them up at a drugstore in Iowa? And they said, no, we can't do that. Because we don't know for sure if you're the one picking it up. I mean, there are checks and balances in that. But I think the challenge with pharmaceuticals, it can be challenging for sure. Now, with regard to security, we all know there are computer geniuses sitting somewhere in a coffee shop in their bedroom that are plotting to destroy the world, metaphorically. Right? I mean, you could say, I mean, and this we saw during the election, right? I mean, there's a whole concept of the data that Facebook takes, and there's ways of putting out false stories. And in fact, I tell my students all the time, I said, it's conceivable that someone could put together a news story. They could go out to the Reuters or UPI or BBC or CNN or whatever news outlet and says there's an outbreak of Ebola virus in this children's hospital and 5 patients have died. And that news story will pick up momentum in a matter of seconds around the world. And that will cause the children's hospital, at least the one near where I work, to batten down the hatches and automatically go into PPE, personal protective equipment, and spend $500,000 in a matter of hours because it's a hoax. So as we develop more and more advanced computing technologies, we also have to be cognizant and aware there are people out there that will try to steal data, whether it's patient data, whether it's financial data, whether it's Medicare numbers, Social Security numbers. And there are also those who also have to continually address that on the side. So I can build this device, but I also have to make sure the programming is safe and secure. And so in the past, I just built a device, right? I built a pen or I built a car. Now, with cars, they have these smart systems in them to allow you to track where the car is and actually look at data sets coming from the car's performance and can shut the car off remotely. So you have to constantly be aware of this security threat because the most important part, I mean, no one really cares, for instance, if a politician has a sexually transmitted disease or has a mental illness. I mean, they care, but as long as they do their job in this day and age, no one really cares. However, if John Doe is sitting in a coffee shop and he overhears somebody talking about one of his neighbors, his neighbor has come down with breast cancer. That's private. In the United States, there's privacy of medical records. I'm sure in India there's laws that protect patient privacy and public personal private information. So there always has to be this blanket of awareness that we have to constantly be on our guard, if you will. I mean, before you just put money in the bank. Now you can take money out of the bank without ever going into the bank. So it's a different world. Things have changed drastically, and it will continue to change. But as it changes, we continually monitor that change.
Correct. Yes, sir. And the last question that we have for both of you are, what do you think would be the additional benefits that the doctors will have when they start using telemedicine? So this question is for the doctors who have still not been using telemedicine. So just want to give them a perspective of the benefits that they will get once they enter into the telemedicine for their particular practice, in their clinical practice.
So in the United States, if let's assume for a minute I have a patient population in my clinical practice in a small rural area of 5,000 patients encounters a year, and those are face-to-face where people come into my office and sit. They drive some distance, several hundred kilometers, to get to my facility. They sit in the waiting room, looking at last year's magazine or 2 years ago magazine. And I see them for 15 minutes. They go out pay for parking, and then drive back 100 kilometers home. Or I see them by telemedicine where they stay in their home, and now I can see a lot more patients, so my revenue goes up. I can address someone's medical concern sooner than later. With technology, I can actually identify that somebody has a precondition of diabetes when they're 8 or 9 years old, and not wait till they're 80 or 70 or 60 years old. I can actually manage my patients in a better way. So telemedicine introduces cost savings to the healthcare system overall. It also provides us better opportunities to manage our patients remotely, so the convenience of trying to keep the economy going, but also one of the things that I've seen many people write about is going green credits, carbon footprint, where you begin to now say, well, like we'll just use COVID-19 as an example. The water in Venice, Italy became clear and the dolphins were swimming in it, right? Because if no one's using the water. And pollution is dropped by 15, 20% around the world because people aren't driving. Well, if I'm not driving to the doctor, thousands of patient encounters, millions of patients encounters around the world, and they're staying at home and they're not taking the bus, they're not taking the high-speed train or whatever it might be, the car, the rickshaw, they're staying at home. That also impacts not only the economy, but also impacts the environment.
Dr. Shambhu, I want to add on the previous question.
Sure, Dr. Murthy, please go ahead.
Yeah, the previous question you had two parts. One is the security and privacy of the data, and the other one is the receipt of the prescriptions or anything. They are equally important and almost equal in the personal consultations as well as in the digital consultations. But in the digital consultations, it has to be a higher level of confidentiality and the security system which have to be built in. And as we know, the more antivirus systems we build up, one more no virus will come. The same way, we will be strengthening the systems and the systems structure and the infrastructure at the hospital providing the telemedicine. And more ways of leakage or proliferation will come, and we have to overcome that with a more advanced development. And as far as the prescriptions are concerned, they are bound to be equally received even in case of the physical or personal consultations also, because particularly in case of the psychiatric patients, where some prohibited drugs are there. Now, thanks to the telemedicine practice guidelines, they have divided or classified the drugs as class A, B, O, etc., where they can be given across the counter, they are given for the general treatment, or only in acute conditions for the known conditions of the known patients with a particular disease or a symptom. So definitely the precautions are built in, and nevertheless there will be some loophole. People will be trying to misuse that, and there have to be some effort, continuous effort. This is a closed loop effort to bridge the gaps.
Right, sir. Thank you, Dr. Murthy. Thank you, Professor Charles, for the wonderful Q&A session and answering the questions that our live speakers put up during the session. I would now like to just quickly invite Harsh, who is the expert on a telemedicine app, on the DrOnA app that we are advertising and we are promoting. And the live viewers would love to see as to how telemedicine app works. So quickly putting on to Harsh, can you please take us through your short presentation, please?
Sure. Thanks a lot, Dr. Shambhu. Am I audible?
Yes, you are loud and clear.
All right. Thanks a lot. It's a privilege, everyone, to be here on this call and following the stalwarts of telemedicine like Professor Charles and Dr. Murthy. I mean, it's like effort of people like these that, we have seen any kind of movement or development in this area, right? And it's a privilege and honor to be speaking in the same conference after them, right? very quickly, we'll try to get into the details of telemedicine and what does DrOnA Health has to offer, right? All of us understand now that teleconsultation has become the new normal. Patients are not able to move out of their homes, and this technology comes like a boon at this point of time to allow for continuity of care, right? And with the official guidelines from Ministry of Healthcare and Family Welfare being in place, it actually helps platform like ours to bring an official version of system which can actually help both patients as well as doctor in delivering care, especially primary care, to the last mile, right? And if we look at what has been happening in India for last 3 months, we would see that week on week, the number of teleconsultations have tremendously grown, right? And all news publications and media houses have been reporting on this. And this also comes as a boon because of all the benefits that Professor Charles and Dr. Murthy were talking about during their presentations. But what is the most important and striking factor that I felt from the overall conversation, and it was reflected in what both of them said, that implementation of any technology is dependent on people, right? It is about the leadership and how all of us, and especially the doctors, how well do we accept this technology in our own practices, and how we can make this part of how we practice in our day-to-day lives, right? If doctors lead this, patients will follow, and that's what our understanding is. So presenting DrOnA Health, and here we would like to take you through the benefits that we have on DrOnA Health and how you can really benefit from that. So DrOnA Health is powered by Remilla. We have developed this platform solely to help doctors in connecting with their patients and continuing the care, right? A brief introduction about the team which is behind this platform. Remilla is actually founded by three of us. Dr. Ruchir, who is a medical doctor and has worked in healthcare space for last 12 years. He has worked across consulting firms, working for various pharma and hospital companies, and then worked with Fortis for 5 years before he started this platform along with us. I am Harsh Bansal. My background is engineering and then management degree. I've worked across companies like Microsoft in technology and businesses and e-commerce. And Richik, who is our third co-founder, he's a complete out-and-out technology person. Comes from a family of doctors. Worked in US for 6 years before he moved back to India and developed this platform along with us to impact healthcare in India. DrOnA Health has actually just been just launched last week, and last 1 week we have onboarded more than 5,000 doctors who are right now on the platform and using it. Right, so that's a big shout out to everyone who's involved, to all the doctors who have accepted the platform and started using it, all the people who are involved in making this a journey worth striving for all of us. What we'll try to do is we'll just try to very briefly cover all the important factors and benefits that are there on the platform, which differentiates and make it one of the most user-friendly and beneficial platforms for the doctors, right? And then we'll just take it from there. So basically, DrOnA Health is like your own personal branded virtual clinic. It allows you to manage or extend your services across to all your patients, no matter where they are, right? You can edit your personal clinic. It's as simple as just clicking this button and setting up your clinic. It hardly takes 5 minutes to set up your virtual practice. You can actually share your clinic's link with all your patients by clicking on the share link that is there on the homepage of the application. You can use the same link and publish it across your social media profiles like Facebook, or share it with your patients using your assistant's help. So your assistant can actually send out this your personal link to all your patients. You can publish it on your prescriptions. You can paste it on your clinic, right? So it is as simple as putting a link out there through which all your patients can get in touch with you, book an appointment with you, and easily get an access as per your time schedule, right? So the platform allows you to extend your practice in the virtual world. And these are more examples on how you can put this link out there to all your patients. So it could be on your WhatsApp status or DP as well, right? The next thing is, how can you upload all your existing patient data in one go on the platform? Because it's important to get all your existing patients on the platform so that you are able to extend them the digital care through the platform itself, right? Again, it's as simple as putting all your patient list in one place. You can upload patients one by one, or you can upload all your patients' data at one go by getting in touch with our customer care. So whether you have all your patient list in an Excel file, or whether it is in form of photos in your register, you can just share that with us, and we will help you get all your patients on the platform at one go. The good part is that, you know, it's your private practice and your patients get access only to you. So it's your safe place to have all your patients and give them the right care that you want to provide. At the same time, in one single platform, you are also able to manage all your patient data, patient records, and patient history in one single place against the patient, right? So this actually helps you not just in connecting with the patients remotely when the need is, but also have the complete patient history in one single place, so that whenever the patient is visiting the next time, at that point of time as well, you have the whole history of the patient there for your perusal, so that you can actually treat the patients accordingly, right? So even if the patients in physical practices as well, you a lot of times you would have struggled with the fact that the patients have not brought their prescriptions, and you have to check and remember the history of the patient. But here, everything is there at your fingertips. One of the important feedbacks that we got from the doctors was that the financial management of all these consultancy and telemedicine practices were actually very difficult for them. But what we have tried to do is we have tried to really simplify everything for the doctors. We have gone ahead and actually implemented the best system which is out there to give you the next day settlement, right? So your patients complete their consultation today with you, and the next working day itself, you get your payment in your account. So we have created a very robust system and an automated system to completely ensure financial transparency as well as promptness to ensure that the doctors can focus all their attention on their consultation and their patients, and leave everything onto the platform. Dr. Murthy and Professor Charles both spoke about how it is very important to secure the data, and how it is important for the doctors and patients to be able to control this, right? So on our platform, we have ensured that all the latest protocols to manage security of the platform is used. We use Amazon as our web services partner, which is one of the world's most secure and robust platforms to store and have data. At the same time, the fact that we actually give complete control in the hands of doctor, right? So as a doctor, you can choose at any given point of time, you can choose to deactivate your account and take all your patient history along with you, right? This kind of control is not available anywhere else on any of the other platforms which are out there, right? So we actually allow the doctors to handle, manage, as well as choose to be on the platform or go away at their own will, right? You can use the platform to manage your complete patient history, whether it is for your online consultations, telemedicine, or whether it is your offline consultation. All of that is on one single platform, and all this data is controlled from one single place, right? So you can choose to download or delete any given point of time. So the next important factor is, as we understood that telemedicine is the new normal, and what we will see in the months to come, that it would be an online plus an offline world, which is a hybrid scenario. A lot of your patients will want to consult with you in person, and there'll be a larger number of patients who would want to do their follow-ups online as well, right? And that is where, as Dr. Murthy spoke about, that 90% of the patients are the cases where the doctors don't even need to touch the patient in order to give them a follow-up. And that's where this platform really comes out and helps. You can actually manage your offline as well as online consultation through one single platform. You can manage all your slots, all your consultations in one single place. And as a doctor, if you look at it on the right-hand side, you can actually see your complete schedule in one single place, whether it is a video consultation, and if you want to just launch the video consultation right from the app, or whether it's a physical consultation, and if you want to, if you're actually seeing the patient physically and just want to upload the patient's record at the end of the consultation, right? In either case, you can just manage all of that in one single place. At the same time, for all your online consultations, you can also see which are the consultations which are completely booked and the patients have already paid for, or they have yet not confirmed their appointments with you. So it actually gives you a very simple way of managing your complete practice, whether it is online or offline, in one single platform, and store all your patient data, patient history, again, in the same place. Next unique factor about this platform is the simple mobile site, which allows the patient to access their doctor, right? Which is, as a doctor, you get like a personal website, which you can actually give out to your patients to reach to you. This is the same link that we spoke about earlier. Here, what really happens is that the patients actually get to see your personal clinic or your personal web page, like your website, and they can actually see all your details, which is also in line with the telemedicine guidelines, so that your registration number is also visible to the patient, and they get to see your details. At the same time, they are able to actually book appointments with you directly from this website. All your available slots are visible to your patients through this, and they can just go ahead and make a booking right from the website. At the same time, at the time of consultation, they can actually, once they have booked an appointment with you, they can also upload their past prescriptions, so that you can actually see all of that within the app, and they can start the video consultation right from this website itself. The interesting fact is, even though there is a patient's app, the patients can actually download the app and make the complete consultation with you. But at the same time, even for the patients, some of them who are not really digital natives, or they're not very comfortable with downloading an app and then consulting, our platform actually allows for the patients to consult with you even without downloading the app. They can actually consult directly from this link itself. And that actually makes it life very simple for both the doctor and the patients, because then patients can consult with their doctor through any mode. So it actually reduces the dependency on the patient's understanding of technology, as well as any device, right? So whether it is an Android or an iOS, any mobile device, patients can actually download the app and consult, or even without downloading the app, they can actually still go ahead and use the browser to consult with their doctors. So that's it from the platform's differentiation point of view. There are a host of other features which are there on the platform, which actually makes it very simple for both the doctor as well as the patient to use the platform. Just to summarize, it's your personal branded virtual clinic. You can have all your patient history, patient data in one place. The finances are very transparent and simple, and it leads to next day settlement. There's 100% control that you have over your own data. It helps you in managing your complete online and offline consultation in one place, and you get a personal mobile site for your patients to book an appointment with you. At the end of this, I think there would be a poll which will be given out to all of you, where you can just select if you want to get in touch with the Mankind representative who would help in any kind of registration that is required for if you are interested in the platform. And there's a big shout out that I would like to give out to the whole Mankind team, the complete field force, the sales and marketing team, their operations team, and the leadership who has actually made it possible for this vast and widespread leadership in actually taking this technology across the country to every doctor possible who can actually help their patients in managing their care going forward on an ongoing basis, right? And all the Mankind representatives are actually available for any kind of support that is required in order to get started on the platform. And they would be more than happy if any of you want to just reach out and just probably even just press a yes on the poll, so that we can get in touch with you and get you started on the platform. That's it from my side. Thanks a lot, everyone, and it's a real privilege to be here. If there's any questions, I would be very happy to answer them.
Right. Thank you, Harsh. So here we conclude our live international webcast on telemedicine. I would like to thank our honorable speakers, Professor Charles and Dr. Murthy. And I would also like to thank Harsh for the informative demo. Now, I would like to just take the final closing comments from the speakers, if any.
I just wanted to express my thanks and appreciation for the opportunity to participate. I enjoyed Harsh's comments and Dr. Murthy. I think telemedicine and telehealth and mobile health and e-health and all these different monikers are really become a part of the fabric of medicine moving forward. I think going backwards is not an option. I think that the more and more, the world has gotten smaller and smaller, even though it didn't shrink in size. Human society is closer and closer together, but yet farther and farther apart for a variety of reasons. But I think telehealth, telemedicine, and the other tools that we have can bring us closer together, and we can share knowledge and share experiences. And I really appreciate the opportunity to do so. I will sign off now. Thank you so much for participating and for allowing me to ramble on.
Thank you, sir. Right, sir. Dr. Murthy, your final comments, please, if any.
Thanks again to the organizers for conducting this session and inviting me to talk. And it's a pleasure to meet with the Professor Charles and the other international and national audience this evening. I would like to say and assure the practitioners in India who are either not aware of the telemedicine or who are aware of telemedicine but not practicing, that the telemedicine practice guidelines are in place. They are very much issued by the Ministry of Health and Family Welfare, and all your interests and the security things are taken care by the practice guidelines. Rest assured, start the telemedicine practice for the benefit of you, your practice, and for the benefit of the patients as well. And the last point, another point I want to mention is to all the participating doctors to become members, life members or institutional members or corporate members of the Telemedicine Society of India, which I represent, to become crusaders and the team to build a mission telemedicine in India, to put all our resources, ideas and energies in a synchronized manner. Once again, thanks to one and all.
Thank you, sir. Thank you for the continuous support for the Telemedicine Society of India. I would now like to bid adieu to all the viewers and the speakers. This was Dr. Shambhu Mandal from the Knowledge Partners Act for ESH, and on behalf of Mankind Pharma, would like to thank the speakers and the viewers once again. Thank you and
Before
have
we
a
sign off,
wonderful
can I know
evening.
how many participants are there?
So there were more than 10,000 participants, live viewers during the session.
10,000.
10,000, right.
Okay. Great.
Right, sir.
Okay.
Right. Thank you. Thank you, everyone.
Thanks.